This slideshow will discuss infections of the lower respiratory system, specifically talking about TB. Tuberculosis, or TB, is a very contagious disorder of the respiratory tract. And it is something that if you take care of people with TB, you will need to work with them in isolation. And when you send them home, you will need to teach them about infection control. Tuberculosis is an infectious disease which often occurs in the lung and is characterized by lesions in the lungs. It may also affect other body tissues, and this is known as extrapulmonary TB. Other frequently affected areas are bones, the meninges, the urinary system, and the reproductive system. There is a disease that causes a kyphosis or a hunchback called Pott's disease, which used to be common, but it is now quite rare in the US. Tuberculosis is caused by the tubercle bacillus, Mycobacterium tuberculosis, or M. tuberculosis. There is a method of staining that they use to identify it in the lab that uses an acid stain, and so they call this an acid-fast bacillus, AFB. So when you send sputum cultures off for TB, you will send them off as a culture for AFB, and that's how they identify it in the lab. M. tuberculosis can live in dried sputum and dark places for months, but it is killed in a few hours when it is exposed to direct sunlight. The lesion that you see here on the X-ray is pulmonary TB, and these continue to degenerate. They can become calcified, they can become necrotic, and they can heal and become fibrotic, and it's just this calcified nodule that sits there in your lung tissue. It doesn't really do much, but it also is an area where there's no ventilation and no gas exchange taking place. So it basically creates dead space. The disease is spread by droplets. So it's spread by inhalation of the M. tuberculosis bacillus from droplets of an infected person. Once in the lungs, the bacilli multiply and disseminate. They move to the lymph nodes and then they move to other parts of the body. In the lungs, the immune system surrounds the area with neutrophils and alveolar macrophages. This creates a lesion called a tubercle, which is what you saw on the x-ray in the previous slide, and it seals off the bacteria and prevents its spread. Similar things can happen in other areas of the body. The bacilli in the tubercle die, or they become dormant until the immune system is compromised and disease can develop. So this is a person who has been infected, but they may not go on to develop active disease, and this is known as a latent tuberculosis infection, or LTBI. Only about 5 to 10% of the infected people in the U.S. actually develop the disease. And even then, it may not develop for many years. And again, it will usually only develop when you have some sort of an immune system compromise, or when you become older and your immune system is not quite as effective. Your body develops an immunity, it produces antibodies, and it keeps it under control until something in your immune system changes. So this is a little diagram of a normal lung with a normal alveolar sacs. They kind of look like bunches of grapes. And then comparing that to a lung which has been infected with TB. You'll notice that there are some initial little infected areas there up at the top. There's a calcified lesion. A little later on, that lesion has progressed to cavitation, which means that the inside of the lesion has necrosed and died. And then later on, there's extensive disease with cavitation. And if you think about it, when you have these areas of cavitation, as I said before, no gas exchange takes place in these areas. And so it really decreases the surface of your lung that is available for gas exchange. You'll also notice that there are large lymph nodes along the large airways. This slide compares and contrasts latent TB with active TB. Latent TB infection, or LTBI, is again infection with M. tuberculosis, but there is no active disease. It lives, but it doesn't grow in the body. It doesn't make you feel sick or feel like you have symptoms, and you can't spread it from one person to another. It can, however, advance to active tuberculosis, or what they're calling on this slide tuberculosis disease. How that happens, as we talked about earlier, is if the immune system is weakened by a serious illness, maybe HIV, maybe you have become immunosuppressed because of cancer treatment, or when you're older, your immune system is less efficient. And then the LTBI develops into active TB. You have symptoms, and you can spread the disease from one person to another. It can also cause death if it's not treated. Some older adult considerations. The age-related decline in immune function decreases the effectiveness of the TB antibodies that your body has made. With LTBI, then the bacilli can be activated and then cause active disease. We've already talked about that. Decline in immune system can also impact the clinical manifestations of TB and cause fewer symptoms. And so if you're older, you have a less efficient immune system, the disease can become active, but you may also have fewer symptoms than a younger person. This is really important in terms of screening for older adults, Because of the risk of a false negative, because you have a decreased effectiveness of your immune system, two-step testing is recommended for older adults. Most residential care facilities require TB testing on all new residents, and some require ongoing serial testing of all residents. Risk factors for TB are when people are living in crowded, poorly ventilated living conditions. Older adults are at higher risk. In the US, urban poor and underserved immigrants are at higher risk. Lately, just TB in general has increased because of an emergence of drug-resistant strains and ineffective treatment programs. So this is not true in the US, but if you look worldwide, 1/3 of the world population is infected with TB. That's a lot. Some cultural considerations with tuberculosis include higher incidence in American Indians, Alaska Natives, Asian Pacific Islanders, Black, non-Hispanics, and Hispanics. The disease is most prevalent in people older than 65 years of age in these groups. When you have people who immigrate to the United States, new immigrants from areas where TB is prevalent have incidence rates similar to those from their former country. And so when you have people who immigrate who live in fairly close-knit communities, the incidence of TB remains high in those communities. TB prevention is not that much different than prevention from any other infectious disease. Living in clean, well-ventilated areas is very important. And if you do have someone who either has a known case or a suspected case, respiratory isolation is very important. Living a healthy lifestyle and living in a clean environment is important. And then some areas where you have a very high risk will get TB vaccine. It's abbreviated BCG. And many people who are born outside the United States get BCG during their childhood before they immigrate. And then those are the people who wind up with the positive skin tests and people who have to have either chest x-rays or immunoassays to determine whether or not their TB antibodies are from their vaccine or from active disease. Prevention will ultimately come from adequate treatment of those who do have the disease. This slide illustrates the signs and symptoms of TB. There is a cough, a low-grade fever in the afternoon, anorexia and weight loss, sometimes significant weight loss, fatigue, night sweats are common, and sometimes hemoptysis. You can get a tight or a dull chest pain, and when you cough, your sputum becomes mucopurulent, thick, yellow, and it'll have, as we said earlier, hemoptysis, streaks of red or rusty sputum is common. If effective treatment is not initiated, a downhill course occurs with those lesions becoming fibrotic, and you get cavitary lesions, which means that there's necrosis in the inside of them. You get hemoptysis and even more progressive weight loss. Complications outside the lungs can occur from the bacilli spreading throughout the body, and those can include pericarditis, meningitis, bone and joint infections, and GI or GU infections. This is the first of two slides that discuss the skin testing for diagnosis of tuberculosis. A liquid that has a purified protein derivative suspended in it called PPD, purified protein derivative, is what is used for skin testing. So what they do is they take parts of the TB protein and suspend it in this liquid, and then you inject it in an intradermal injection underneath somebody's skin. Then you wait a couple of days and see whether or not they react. So the picture up at the top is what a positive might look like. You're measuring the bleb there, the wheal. You also can measure the redness around it. You can see in the little diagram, you put the needle in and make a small bleb with the infusion of the serum. Use half cc, and then there are different categories of people for whom a positive test is different, and we'll go talk about that a little bit more in the next slide. But before I get there, I want to talk about one-step testing versus two-step testing. TB is interesting. It has what we call an amnestic immunity, amnesia, forgetting. So you've been exposed to TB and your immune system attacked it, walled it off, and made LTBI, and the bacteria inside there either died or became dormant. You made antibodies for this. But as time goes on, your body's not seeing any more active disease, so your body kind of forgets it's there and doesn't make more antibodies. So when you get a one-step test and you get a negative one-step test, that could mean either you've never seen the TB bacillus before and never made any antibodies for it before, or it could mean you've seen it and you've got latent disease and your body's not actively producing antibodies anymore. So that first step of the two-step wakes up your immune system, and then it's like, oh, I've seen that before. I should probably start making antibodies again. So then 2 weeks later, technically between 1 and 3 weeks later, when you go in and have the second skin test done, it will detect the PPD that was just injected. Your body has started to make antibodies against it, and so you'll get a local reaction. So what happens is, if you do have LTBI, the first step of the two-step wakes up your immune system and causes it to start producing antibodies. The second step shows a reaction because of that antibody production, and that's why it's necessary to have a two-step test. After you have initially had a two-step test, then most facilities will only require you to have a one-step annually after that. So all positive TB tests are not created equal. Depending on which risk group you belong to, you interpret a skin test differently. So we'll start at the bottom. If you are a person with no known risk factors for TB, anything greater than or equal to a 15 millimeter reaction is positive. Anything less than that is negative. If you have somebody who is a recent arrival from a high prevalent country, an IV drug abuser, a resident or an employee of high risk congregate settings, like for instance, a resident of a long-term care facility, somebody who is a lab personnel who works with mycobacterium, somebody who's got comorbid conditions, other chronic illnesses, children less than 4 years old, and infants, children, and adolescents who live with and are exposed to people in high risk categories. Those people, anything greater than or equal to 10 millimeters is a positive test. The third group of people are very high risk. If they're HIV positive, if they've had recent contact with an active TB patient, they have nodular or fibrotic changes on their chest x-ray, or they've had an organ transplant and are therefore immunosuppressed, those people, anything greater than or equal to 5 millimeters is a positive test for TB. We talked about a skin test being the first step to diagnosing. Another way to diagnose is with a blood test or an immunoassay for TB antibodies. The most common one we see in this area is called the quantiferon gold test. What this does is this blood test differentiates between antibodies that your body has made in response to BCG, which is the TB vaccine, and antibodies that are made from an actual infection with the mycotuberculum or Mycobacterium tuberculous. So if you've had BCG and you have a positive skin test, having this blood drawn will show that your antibodies are indeed from your vaccine and not from a TB infection. Another way, of course, is to look at a chest x-ray. So if you have a positive TB test, you can have a chest x-ray, and if your chest x-ray is clear and you have a history of having a BCG vaccine, then they will assume that you're okay. If you have symptoms, the definitive way to diagnose it is sputum cultures. Sputum specimens are essential to confirm the presence of TB. Specimens should be from lung secretions and not from saliva. So refer back to the respiratory diagnostics lecture that I did and talk about how to get a good specimen. Use 3 negative AFB cultures are required to rule out TB. 3 negatives are required to rule out TB. So you collect 3 specimens on 3 different days. A spontaneous morning sputum is more desirable than induced specimens, because remember, if you're laying around at night, you have a lot of time for the secretions to pool in your lungs, and so you'll get a better specimen. You collect the sputum before the treatment is initiated. It's just like anything else. You do the culture before you start the antibiotics. This slide lists a lot of drugs that are used for the treatment of active TB. They are very specific antibiotics meant for the Mycobacterium tuberculosis, and they must be taken for an extended period of time. The first-line drugs have fewer adverse effects, but they can still be toxic to the liver and the central nervous system. The second-line drugs listed here are more toxic, and they are only used when cases don't respond to the first line drugs. Remember, I talked about there's a lot of resistant TB out there. Often they will give 2 or 3 drugs, sometimes up to 4 simultaneously. And there are combination drugs available so that you don't have to take 4 different pills. But the reason they do this, it's very similar to cancer chemotherapy. They do it so that lower doses of each drug can be given, which reduces the adverse side effects and reduces the risk for developing bacterial resistance to the disease. These antibiotics for tuberculosis need to be taken for 6 to 9 months. And if you have multi-drug resistant TB, for 2 years. Now think about this. Adherence is often a problem. It is very difficult to get people to take medication that can give them side effects for 6 to 9 months, let alone up to 2 years. So adherence can be a big problem, and that's one of the reasons that we have multi-drug resistant TB. Besides the antibiotics that are used to treat TB, there's also supportive treatment, rest, fluids, good nutrition, and of course, isolation. Quite often, they will treat an LTBI in order to reduce the risk of progressing to active disease and therefore to reduce the risk of the spread of the disease. And so that will consist of taking one or more of the antibiotics for a certain period of time, usually much less than if you have active disease. The protocol depends on the antibiotic or different kinds of antibiotics that are used to treat it. If you were writing a nursing care plan for the management of tuberculosis, here are some of the diagnoses that might be used. Ineffective breathing pattern related to decreased lung capacity. Remember, I talked about how the lung capacity is diminished when you have those tubercles because no gas exchange is taking place there. Non-compliance or non-adherence is big because people don't understand the knowledge of the disease process and the long-term requirements for treatment, and they just are not willing to take that much medication for that long a period of time. Activity intolerance, which is of course related to the fatigue because they're febrile and also because they really can be malnourished with TB. And then imbalanced nutrition related to anorexia, not just from the disease, but also from the drugs used to treat the disease. Extreme fatigue and a productive cough. Cough just wears you out, and people don't eat a lot if they're coughing all the time. With the increase in the incidence of multi-drug resistant TB, people often rely on what they call directly observed therapy, DOT, directly observed therapy. This is recommended for people who are known to be at risk of non-compliance with therapy. So what this consists of, it's visual observation of the ingestion of each required dose of medication for the entire course of treatment. So think back to mental health, how you had to visually observe ingestion of the medications and look around to make sure that they took it. Think about this. Follow-up visits are necessary for 12 months. And a public health nurse often administers the medication at a clinic site. This is a lot of follow-ups. This is a lot of money. This is a tremendous amount of effort that the person has to put forward and that the healthcare provider has to put forward. There are also follow-up visits after completion of therapy to monitor for the presence of resistant strains. If you have people who are homeless, you'll have a public health nurse, not necessarily at a clinic, but will go out into the field and administer the directly observed therapy. Complementary and alternative therapy. This is really interesting. Vitamin D has been found to be successful in the prevention and treatment of TB. White blood cells convert the vitamin D into an active form that helps to make a protein that kills the TB bacteria. So years ago, they used to have what they called TB sanitariums, and these were usually located in a sunny climate, and there was always a sunroom environment. in these places, and maybe that's why they maybe didn't understand about the vitamin D, but they figured people got better in those sunny climates when exposed to a lot of sun. And so that's why they had the sanitariums with the solariums. The World Health Organization, the WHO, is very involved in TB prevention and treatment, and they have a global plan to get rid of TB around the world. It's a very ambitious plan. The facts that the World Health Organization uses in their TB campaign is that TB is one of the top 10 causes of death worldwide. Certainly not in the United States, but if 1 in 3 people in the world has TB, it makes sense that it's one of the top 10 causes of death. In 2017, 10 million people got TB and 1.6 million died. And of those, 0.3 million were people with HIV. TB is one of the leading killers of HIV positive people, which makes sense because those people are immunosuppressed. In 2017, a million children got TB and 230,000 died, including children with HIV-associated TB. Multi-drug resistant TB, MDR-TB for short, is really a public health crisis and a health security threat. The WHO estimates that over 500,000 new cases with resistance to rifampin, which is the most effective first-line drug, and of which 82% had multi-drug resistant TB. You know, there's a lot of things that are scary to me in terms of things I wouldn't want to get in my life, and multi-drug resistant TB is one of them. Finally, back to the World Health Organization global plan to end TB. There's been such an increase in the incidence of multi-drug resistant TB and XDR-TB. Now, XDR-TB is a strain that is resistant to all drugs. Think about that, resistant to all drugs. So there's nothing that will kill this. And because of this increased incident, the WHO's global campaign has taken off in the last few years to try to stop the spread of the disease. The goal is to eliminate the disease by 2050. And to do that, they are looking to pursue high quality directly observed therapy expansion, to address TB infection and HIV, to address multi-drug resistant TB, to contribute to strengthening our health system, and engage all healthcare providers in diagnosing and treating and preventing TB. Empowering people with TB and their communities, really teaching them how they can help themselves, and of course enabling and promoting research to try to end TB by 2050.